Algorithms, the oligozoospermic male. At the conclusion of this presentation, participants should be able to define the characteristics of oligozoospermia, outline the investigations for oligozoospermia, and describe the management approach for oligozoospermia. Oligozoospermia basically means low sperm concentration. According to the World Health Organization (WHO) 2010 lower reference values, sperm concentration should be 15 million per milliliter or above. Thus, oligozoospermia is defined as sperm concentration below 15 million per milliliter. Oligozoospermia can be associated with other findings, such as asthenospermia, teratospermia, and leucospermia. Some clinicians consider sperm concentration below 5 million per milliliter to be severe. It should be kept in mind that such definition is purely arbitrary. When interpreting sperm concentration, it should be kept in mind that the WHO reference values do not distinguish fertile versus infertile men. In other words, just because the sperm concentration meets the reference values does not rule out the possibility of any underlying conditions that can contribute to the infertility of the couple. Thus, the WHO reference values should not be used as the only criteria to exclude or include the male partner for further fertility evaluation. This is an algorithm for the management of infertile men with oligozoospermia. This presentation will provide details on the use of this algorithm. Please keep in mind that this algorithm merely serves as a reference. Clinical judgment must be applied to guide your approach to properly evaluate and manage these patients. A detailed history and physical examination is the first step in the evaluation. The main purpose at this phase is to rule out any significant health conditions that may be associated with or first present as male infertility. One should also focus on any correctable factors that can enhance the fertility status of the patients. This may include a wide spectrum of lifestyle behaviors that can be modified. Examples of serious conditions that may present as infertility include testis cancer, osteoporosis or osteopenia, and various endocrinological and genetic anomalies. Lifestyle factors that can be modified include weight reduction, stress management, reduction of tobacco and drug use, and exposure to other gonadotoxins. In this list of common conditions that can contribute to male infertility, notice that many can be treated and corrected. When taking a history and performing a physical examination, one should focus on these conditions to evaluate if treatment can be beneficial. Semen profiles in men may fluctuate. Thus, the semen analysis should be repeated with proper instruction for collection to confirm abnormal findings. Do not make a diagnosis on just one semen analysis. Proper collection of semen should take into consideration the time from the previous semen analysis, at least 1 to 2 months, abstinence period, 2 to 5 days, and any health factor, such as febrile illness, that can affect the results. These important tests should be performed by a reputable laboratory with qualified technicians. The following events and factors are unlikely to result in oligozoospermia, but should be mentioned. Accidental spillage of semen from the container will result in reduction of total semen volume, but the sperm concentration in the remaining semen should not be affected. While retrograde ejaculation may result in reduction in semen volume, it should not affect sperm concentration. Retrograde ejaculation may coexist with oligozoospermia, but it is not a direct cause. The presence of anti-sperm antibodies may affect sperm motility and fertilization ability, but should not affect sperm concentration. The method of transport, storage, ambient temperature, and time from semen collection to analysis may affect sperm motility and morphology, but not sperm concentration. Once oligozoospermia is confirmed, a serum hormonal profile should be performed. Measurement of a morning serum total testosterone and follicle-stimulating hormone levels are the minimum hormonal evaluation for oligozoospermia. Bioavailable testosterone measurement can be valuable, though costly. It is generally not necessary in the absence of other factors such as obesity, thyroid dysfunction, liver dysfunction, or other conditions that can change the level of sex hormone binding globulin. Additional hormone profile evaluation to elucidate the cause of hypogonadism may include luteinizing hormone, estradiol, and prolactin levels. A thyroid profile is generally not indicated except if there are signs and symptoms suggesting thyroid dysfunction. Serum inhibin B is also a valuable measurement in the male fertility evaluation. However, this assay is not widely available and is not part of the standard investigation for oligozoospermia. Can obstruction of the male excurrent ductal system lead to oligozoospermia? In theory, partial obstruction may lead to reduction in sperm concentration. This may occur in patients with a history of vasectomy reversal, epididymitis, prostatitis, urethritis, or trauma or iatrogenic injury to the reproductive tract. Unlike azoospermia, in oligozoospermia, the diagnosis of incomplete obstruction of the male excurrent ductal system is difficult to establish. Although surgical reconstruction may be feasible, the risk of making an oligozoospermic patient azoospermic should be taken into consideration when counseling patients. Next, we'll consider if additional tests, such as a genetic evaluation, are indicated in a man with oligozoospermia. When severely impaired spermatogenic function is suspected, a karyotype and Y chromosome microdeletion analysis should be performed. Many investigators would perform these tests when sperm concentration is consistently below 5 million per milliliter, and karyotype only for sperm concentrations over 5 million per milliliter, but when there is recurrent pregnancy loss. Generally, the lower the sperm concentration, the higher the prevalence of finding these genetic anomalies. Genetic counseling should be provided to these couples when anomalies are found. Obviously, if the cause of oligozoospermia is clearly mechanical, such as post-vasectomy reversal or traumatic or iatrogenic injury to the excurrent ductal system, genetic tests are not indicated. Additional tests may be indicated to evaluate either the cause of oligozoospermia or other conditions that may coexist with oligozoospermia. It should be kept in mind that for most cases of oligozoospermia, these additional tests are not necessary. Additional semen analyses may be required to break the tie when results from previous analyses do not concur. After treatment, a semen analysis should be repeated to evaluate for improvement. Although anti-sperm antibodies are not a cause of oligozoospermia, the conditions may coexist. Measurement of anti-sperm antibodies may provide information on the cause of coexisting asthenozoospermia, such as partial or unilateral obstruction, or help counsel patients on the use of assisted reproduction, specifically intracytoplasmic sperm injection or ICSI for sperm-bound antibodies. Semen culture may be indicated to evaluate genitourinary tract infection. Sperm DNA damage may coexist with oligozoospermia. Sperm DNA integrity and reactive oxygen species measurement are covered in further detail in other presentations in this series. Retrograde ejaculation, though not a direct cause of oligozoospermia, may be a coexisting factor. Post-ejaculatory urinalysis may help to establish this condition. When there is coexisting severe asthenospermia, to establish whether sperm are viable, vitality staining may be needed. If a partial ejaculatory duct obstruction is suspected, a transrectal ultrasound may be used to help establish the diagnosis. A pituitary tumor may result in hyperprolactinemia, leading to impaired sperm concentration. An MRI can be used to establish this diagnosis. Varicocele is the most commonly diagnosed cause of oligozoospermia. Clinically significant varicoceles are palpable on a properly performed physical examination. If thorough scrotal examination cannot be performed because of patient sensitivity or when the bodily physique limits a thorough palpation, a scrotal ultrasound may document the presence or absence of varicoceles. Scrotal ultrasound can also be used to confirm the presence of a testicular mass that may indicate the presence of testis cancer, which is the most common solitary cancer in men of reproductive age. For most cases of oligozoospermia, a testicular diagnostic biopsy is not indicated. For severe oligozoospermia, and when obstruction of the male reproductive tract is suspected, a testicular biopsy may be performed to confirm the presence of active spermatogenesis prior to surgical reconstruction. After completing the evaluation, let's discuss the management phase. Generally, for oligozoospermia, there are 4 options. First, if natural pregnancy is feasible, timed intercourse may be an appropriate next step. Alternatively, if the partners do not accept any further fertility management, timed intercourse may be the only option. Surgical therapies such as varicocelectomy and reconstruction of the excurrent ductal system may be indicated to enhance sperm concentration. Medical therapies, whether specific or empirical, may be used to enhance sperm concentration. Finally, the use of assisted reproduction is another important fertility management option for oligozoospermia. The decision algorithm on the management phase will be the focus of the rest of this presentation. The goal of management is to allow natural pregnancy whenever feasible. The female fertility status must be taken into account when recommending treatment. One must be realistic. If the semen profile is too low and normalization is unlikely, assisted reproductive technology, or ART, may be the couple's only option. Other factors that must be taken into consideration in discussing a treatment plan include cost, health risks, and the time required to complete the treatment. While natural pregnancy is always a desired outcome, it should not be the only goal of treatment. Often, treatment of male factor infertility that can result in enhancement of the male fertility status, as reflected by higher sperm concentration, motility, morphology, or sperm DNA integrity, may be beneficial in increasing the success of ART or allowing success with less intensive and costly procedures. The 4 fertility treatment options for oligozoospermia are timed intercourse, surgical management, medical therapies, and assisted reproduction. In some cases, a combination of these options may be required to adequately enhance the odds of successful pregnancy for the couple. In the first part of the management algorithm for oligozoospermia, we focused on evaluation to identify any underlying conditions that impact general health, lifestyle factors that can be modified to enhance the fertility status, and male and female infertility factors. The second phase of the algorithm for oligozoospermia focuses on 5 key questions. The first question is whether there is male factor infertility that may be treated with specific therapies. This list shows conditions that can lead to oligozoospermia that, once corrected, will hopefully enhance the sperm concentration. Proper evaluation to reveal any of these correctable factors, as outlined in the first phase of the algorithm, is critical to improving the fertility status of the patient. Obviously, clinical judgment and experience are important in counseling couples on the various treatment options. The next question is, how likely is the specific treatment to upgrade the fertility status? Here again, the clinician's experience and judgment is important when counseling the couple. Keep in mind that improvement in fertility status does not necessarily lead to natural pregnancy only. Even if assisted reproduction is required, If treatment of oligozoospermia can enhance the quantity and quality of sperm, it can be beneficial to the couple by downgrading the level of ART required, such as from in vitro fertilization to the simpler, less costly intrauterine insemination. Treatment of male factor infertility may take time. Surgery may have a waiting period. After medical and surgical therapies, at least 2 to 6 months of waiting may be required to evaluate if the semen profile is improving. In couples with more advanced female age or poor ovarian reserve, this delay may be detrimental. Thus, the clinician must take into account the role of time in discussion of treatment options. Sometimes the use of ART is inevitable. For instance, the oligozoospermia may be so severe that even after proper treatment, semen parameters are unlikely to return to a high enough value to allow natural pregnancy. IVF with ICSI may be required for women with tubal factors and if donor oocytes are needed. In these cases, treatment of the contributing male factor may still be warranted to enhance the success of ART. However, the need for ART as part of the overall treatment plan should be disclosed to the couples early to prepare them financially and emotionally. Though ART may be necessary, not all couples are ready, emotionally or financially, to accept the treatment. There may be psychosocial reasons, such as cultural, religious, and emotional factors, that impact decision-making. The couple may want to defer treatment for now and reinitiate counseling later. In some cases, when ART is not an option, other treatments may be necessary despite lower efficacy or cost-effectiveness. Based on the answer to the 5 key questions, clinicians may propose to the couple the various potential treatment options. Here are some examples of the various management options depending on the answers to the questions. Negative answers are indicated in boxes with a dark background. In example number 1, there is a specific, correctable male factor, and treatment would upgrade fertility status. A delay in treatment is acceptable, and ART is not necessary. This couple would proceed with treatment of the male factor. In example 3, there is no specific correctable male factor, and ART is necessary. The couple agrees and they proceed with ART. In example 6, there is no specific correctable male factor, and treatment would not upgrade fertility status. The couple does not wish to proceed with ART, and they decide to pursue other options. If assisted reproduction is required, 2 additional issues may come up in some cases of oligozoospermia. First, should sperm be cryopreserved in advance? And second, is surgical sperm retrieval required rather than using ejaculated sperm for assisted reproduction? Extremely low sperm concentration may fluctuate from severe oligozoospermia to cryptozoospermia to azoospermia. Cryptozoospermia is when sperm are found only after centrifugation and concentration of the sample. If no treatment for the male factor infertility can be recommended and ICSI is required, cryopreserving several samples of sperm may avoid the need for surgical sperm retrieval for ICSI, if on the day of oocyte retrieval there are no usable ejaculated sperm. Similarly, for men with severe oligozoospermia with no correctable factors who are not ready to have ICSI in the near future, sperm may be cryopreserved to mitigate the potential risks of further decline in fertility status to azoospermia. If the ejaculated sample is not usable and no cryopreserved sperm are available, surgical sperm retrieval may be required for ICSI. If rare motile sperm are found in semen, would surgically retrieved sperm from the testis provide better outcomes with ICSI? Currently, this is a controversial subject. Although some studies have suggested that sperm retrieved from the testis may have better chromatin integrity, Others indicated that they may have a higher rate of aneuploidy than ejaculated sperm. Finally, in cases of severe oligozoospermia, when there is recurrent failure of ICSI with ejaculated sperm, it is uncertain whether sperm retrieved surgically from the testis will provide better outcomes. Further investigations will be required to answer these questions. This lesson has presented an algorithmic approach in the evaluation and management of oligozoospermia. Keep in mind that fertility status can be a dynamic state in that the patient status may change with time. Thus, after any treatment or a period of watchful waiting, it is prudent to reevaluate the patient's most recent fertility status before providing counseling to the couple. Reevaluation may include semen analyses, serum hormonal profile, sperm chromatin integrity evaluation, imaging, and sperm-bound anti-sperm antibodies if indicated. There are no specific rules for the frequency or timing of fertility status reevaluation. Some clinicians suggest every 2 to 3 months to reflect the duration of the human spermatogenesis cycle. Likewise, changes in fertility status post-treatment may not be apparent until months or years later. Thus, information from the most recent fertility status reevaluation is important when counseling the couple. Reevaluation of the couple's fertility status should be performed even after previous success of ART, particularly if it happened remotely. A physical examination should be performed when reevaluating the male fertility status, as new findings may have appeared since a previous examination. Proper counseling depends on their current fertility and psychosocial status. Do not just recommend the same treatment as before without an in-depth reassessment. In summary, oligozoospermia is a commonly encountered scenario in male fertility management. Proper evaluation, beginning with a detailed history and physical examination, is the key to identifying correctable causes. Feasible management options include specific surgical and medical therapies, empirical therapies, and assisted reproduction. The best management option will depend on the cause of oligozoospermia, treatment efficacy and cost-effectiveness, and additional psychosocial factors of the couple. Thank you for participating in this educational activity.